respiratory physiology. It's always where I started with all of my revision when I was at medical school. It's probably got a lot to do with why I've chosen the career that I am doing now in terms of doing anaesthesia, because it's just so important in terms of managing patient care well. So I've devised 10 SBA style questions and then explanations for each of them. There'll be time for you to answer each question as we go along. Don't get too bogged down in if you don't get the correct answer. Every incorrect answer now means that you're learning something, so just don't put too much pressure on yourselves. I hope that it's really useful for you, okay? The objectives of this session is to go over the key kind of core topics in respiratory physiology. So we're going to do a bit about the mechanics of ventilation, a bit about the oxygen cascade and transport of oxygen and carbon dioxide, a bit about control of ventilation, and some bits about spirometry. Okay. So without further ado, our first question: why is the partial pressure of oxygen in arterial blood lower than that in the alveolus? Is it due to humidification? Is it due to mixing of gas with the alveolar gas? Is it diffusion across the capillary membrane? Uptake of oxygen by myoglobin? Or left to right shunting of blood? So we'll give you a few seconds a few seconds to answer that question, and then we'll go through the answers. Okay. So we've got diffusion across the capillary membrane. We've got a few for uptake of oxygen by myoglobin, and then a few for left to right shunting of blood, and mixing with alveolar gas. Okay, so the correct answer for this one is left to right shunting of blood. So what we mean by that is blood that passes from the left, or from, that was supposed to say right to left shunting of blood, and that probably explains why the answer was incorrect. So what we mean by that is shunt is a volume of blood which passes from the right to the left circulation without undergoing gas exchange, so it bypasses the alveoli. This is in comparison to dead space, which we refer to as an area of lung that is ventilated but not perfused. So when we go through the oxygen cascade, we start with atmospheric air. So atmospheric air is, we have 21% oxygen. So the atmosphere is 101 kilopascals. So the atmospheric oxygen is around 21 kilopascals. When it enters the upper airways, it undergoes humidification, and that's in the nose largely. We've got these nasal conchae, which have a large surface area, and they allow the air to become warmed and humidified before passing into the trachea. It stops the trachea from drying out, and it also allows some filtration of all of the nasty things going into our upper airway. As it moves down into the trachea and into the larger airways, we get mixing of this gas with dead space gas, so it reduces from 20 kilopascals to 15 kilopascals. We then have some alveolar gas mixing, so this is where in the alveolus, we start adding in carbon dioxide. So the partial pressure of oxygen goes down again due to this mixing with carbon dioxide in the alveolus. It then reduces again due to this shunt. So even in health, we have a small amount of blood which passes from the right side of the heart to the left side of the heart without undergoing gas exchange. We then have some capillary diffusion. So that brings us down to 6 to 7 kilopascals. And in the mitochondria, we've got about 1 to 2 kilopascals of oxygen. And then it returns to the venous blood, we've got about 5.3 kilopascals of oxygen. So the causes of shunt, so we've got a few different causes. So we've got the Thebesian veins, which drain deoxygenated blood from the heart directly into the left circulation. We also have the bronchial veins, which avoid the alveoli, so they don't undergo gas exchange, and they again, some of those drain into the left-sided circulation. And there can also be pathological shunt, so that's where things are starting to go wrong in terms of health. Okay. So I think that brings us to the end of this question. Does anyone have any questions? What is the significance of the shunt, and why is it affected by partial pressure of oxygen? So the significance of shunt is, so essentially, shunt is deoxygenated blood, so essentially blood that has, for example, oxygenated the heart. We've taken all of the oxygen that we can out of that blood because it's oxygenated the heart, and then that's kind of venous blood, and that's being mixed in with the left side of the heart before leaving the left side of the heart and going out into the peripheral circulation. So it mixes with arterial blood. So that means that you're getting a reduction in the partial pressure of oxygen in the arterial blood because you're mixing some deoxygenated blood in with the arterial blood, if that makes sense. What are the pathological types of shunt? So pathological types of shunt, so that would be things, for example, that would cause the alveoli to not be able to take part in gas exchange. So that would be things like if the alveoli was filled with fluid or filled with infection, they wouldn't be able to get air into the alveoli, but they would still have blood flowing to the alveoli, and therefore you would get further deoxygenated blood rejoining the left-sided circulation. Does that make sense? Okay. All right, so moving on. Which of the following factors would lead to a reduced affinity of hemoglobin for oxygen? So is that increased blood pH, an increase in 2,3-DGP levels, a reduced PaCO2, reduced temperature, or fetal hemoglobin? So we're looking for a reduced affinity of hemoglobin for oxygen. Okay. So, yeah, so we've got 38% are saying increased 2-3 DGP levels, and then we've got a few for increased blood pH, reduced temperature. Okay, that's fine. So, moving. So the correct answer is B, increased 2-3 DGP levels. Okay. So this question, we're talking really about the oxygen dissociation curve. So this is the curve which describes how well oxygen is bound to hemoglobin. So we have a few important numbers on the oxygen dissociation curve. So the point at which hemoglobin is 50% saturated, we call that the P50. And that's an important number, as that's the way that we compare different hemoglobins in terms of their affinity for oxygen. So where the P50 of adult hemoglobin is at 3.5 kilopascals of oxygen, the fetal hemoglobin would be towards the left. So I think it's somewhere around 2.5. Next, we move on to the point at which the hemoglobin is about 75% saturated. That's an important number because that's around the level of the venous hemoglobin saturations, and that's somewhere around about 5.3 kilopascals. So we discussed that earlier in our oxygen cascade. And then lastly, we've got the saturations at about 98%, and that's 13.3 kilopascals, and that's a level of about arterial blood. So the important things about this curve, so it's a sigmoid shape, so that's an S shape, and that's due to this formation or the structure of hemoglobin. So hemoglobin is a 4-protein structure, or a tetrameric molecule, and it's made up of 2 alpha chains and 2 beta chains. And inside those hemoglobin molecules, we've got our ferric ion here. So what I've tried to illustrate here is the deoxyhemoglobin and the oxyhemoglobin. So what happens as the oxygen starts binding to hemoglobin, the beta chains undergo a conformational change and they pull in closer together, and this changes the shape of the hemoglobin molecule. What that means is that they find it easier to take up more oxygen. So that's why, so to begin with here, it's quite difficult to bind to oxygen, and as we increase, hemoglobin binds to oxygen much more easily, and then it reduces again, and that's due to the fact that there are fewer binding sites again because everything's starting to become saturated. Okay, so we get the beta chains moving closer in together, and the binding sites for hemoglobin becoming more available, and they bind oxygen more easily. Okay, so it's all well and good hemoglobin binding to oxygen. We don't just want hemoglobin to bind to oxygen, we also need it to offload it at tissues, otherwise it would be completely useless. So we need it to be able to concentrate that oxygen to areas of tissue that are metabolically active, so the ones that are using loads of oxygen. And this is the way that we do it. So hemoglobin offloads oxygen much more easily in areas that have this kind of high metabolic demand. We can pick this up due to when something's respiring really quickly, the end product of that is carbon dioxide. So increased carbon dioxide causes hemoglobin to offload oxygen. A reduced pH, so if you think about kind of lactate and lactic acid builds up in muscles that are being used a lot. So you get a reduced pH or an increased acidity. 2,3-DGP is it's an intermediate step in glycolysis in red blood cells, and that starts to build up when there's not enough oxygen to complete that cycle. So to increase 2,3-DGP levels encourage the offloading of oxygen and also increase temperature. So again, you're thinking about, doing lots of exercise, getting really hot, offloading loads of oxygen there. The key things that we think about for this leftward shift of the oxygen dissociation curve, or an increased affinity of hemoglobin for oxygen. So fetal hemoglobin has an increased affinity for oxygen than adult. That makes sense again, because if you think about it, in the placenta, you've got the maternal hemoglobin going to the placenta, and then you've also got the fetal hemoglobin there, and the fetal hemoglobin needs to take the oxygen from the maternal hemoglobin. And also methemoglobin, so that's when the hemoglobin becomes methylated and it holds on to oxygen much better. There's a way of remembering what shifts the oxygen hemoglobin curve to the right, aka making the hemoglobin have a reduced affinity for oxygen, and that's this cadet shift right. So carbon dioxide, increased, so all of them are increased, so increased carbon dioxide, increased acid, increased 2,3-DGP, increased exercise, and increased temperature. Okay. And this is just a final illustration of where the 2,3-DGP sits, and it kind of forms this bond so that the beta chains can't move in close together. They can't hold on to that oxygen very well, and they offload the oxygen. Okay. So before we move on to the next question, also more questions about shunt. So is shunt related to VQ mismatching? Yes. So shunt would be an extreme version of VQ mismatching. So that's where you have area of lung that is not ventilated but perfused. Does COPD cause a pathological shunt? Not really, unless it was an infective exacerbation of COPD. The Thebesian veins, so the Thebesian veins, they drain the deoxygenated blood from the heart into the left-sided circulation. Is everyone happy with the oxygen dissociation curve before we move on, or any burning questions? Please repeat the way to remember the right shift. So stand right cadet. So you kind of think about this kind of army lingo. That's one way to remember it. So CO2, acidity, 2,3 DGP, exercise, temperature, and they all are going right. Another way of remembering it is just if you think about it in terms of what happens when you're exercising, what happens to those muscles, and that's kind of my way that I always remembered it. Okay. What happens if you have reduced 2,3 DGP? So you do get reduced 2,3 DGP levels in, for example, stored blood that is potentially going to be transfused into patients. And what happens there is that has a really high affinity of hemoglobin for oxygen, but it just doesn't offload that oxygen at the tissues very well. And so you just get a reduced ability to oxygenate tissues because you're not able to offload that oxygen as well. So it's not very good in terms of being able to utilize oxygen. Could you please go over how affinity affects offloading? So affinity basically means how well does the hemoglobin hold on to oxygen. So reduced affinity means that the hemoglobin lets go of oxygen, whereas a high affinity means that that hemoglobin holds on to oxygen. Okay. So 2,3 DGP makes it easier to offload oxygen, yes. So 2,3 DGP is a intermediate step of glycolysis, so the breakdown of glucose into energy, which is what happens during respiration or cellular respiration. Okay. All right, so moving on. So question 3. What is the tissue oxygen delivery in a patient with a hemoglobin of 150 grams per litre, oxygen saturations of 100%, partial pressure of oxygen of 13 kilopascals, and a cardiac output of 5 litres per minute? So we have A is 816 mils per minute, B 750 mils per minute, C 2050 mils per minute, D 1020 mils per minute, or E 9750 mils per minute. Okay. Okie dokie, so 750 mils per minute. So this question's a bit advanced, and I've kind of included it mainly because it helps to explain one of my slides later on, so I wouldn't get bogged down in this one. The correct answer is D, 1020 mils per minute. The reason that I've included this as part of this lecture is I think this equation is one of the most important parts of respiratory physiology, and I just think that it really helps with understanding of kind of tissue oxygen delivery, which is really what we're trying to achieve in terms of when we're managing someone's respiratory physiology, okay? So don't get too bogged down in this one. So tissue oxygen delivery can be broken down into what is the arterial content of blood, and then timesing that by the cardiac output, because it's how much oxygen is in the blood and how much blood is getting to the tissues, okay? We can break that down even further. So the arterial oxygen content can be divided into how much oxygen is bound to hemoglobin and also how much oxygen is dissolved just in the blood, okay? So the amount of oxygen that is bound to hemoglobin is 1.34, so that number is called Hoffner's constant, times by the hemoglobin and times by the oxygen saturations. And we add that to the dissolved portion, so that's whatever the partial pressure of oxygen is, and we times that by 0.23, which is just a constant that we found, which helps to equate that number to arterial oxygen content, okay? So substituting those numbers into this equation, so 1.34 times by 150 times by 1, plus 13 times 0.23 times 5, so we get 201 plus 3, and then we times all of that by 5, and that's 1020 mils per minute. What we can see by this equation is that this small amount of dissolved oxygen actually doesn't really mean very much in terms of tissue oxygen delivery, and the vast majority of oxygen that's actually getting to the tissues is this proportion of oxygen that's bound. But also what's really important about this equation is no matter how well saturated your hemoglobin is, unless you have a good hemoglobin concentration to start with, your tissue oxygenation isn't going to be brilliant. So we need, in order to get good tissue oxygen delivery, we need to have a good starting hemoglobin level, good saturations, and also a good cardiac output. So we really need a lot of things to be working well in order to be able to get oxygen to the tissues, okay? So 100% oxygen equates to 1.0 in the equation of yes. So we put it as 1.0, so you could either do 100 divided by 100, or, you know, if it was 98%, 98 divided by 100, or you can just do it as the decimal points, because if we think about 100% essentially means 1. Can I go back to the equation? Yes, I certainly can. So here we go. So the 1.34 is Hoffner's constant. So that's just a constant that's been found that we will always times that by the hemoglobin and the oxygen saturations in order to get the bound hemoglobin, and the 0.23, again, it's just a constant that we use. So they're just kind of the standard figures. They don't change around. They're always constant. Where does 1.34 come from? Okay. Is everyone happy with that? I appreciate that it won't necessarily be in your medical school physiology curriculum necessarily, but I think it's a really important equation to kind of get your head around the important points of physiology, and that's why it's included. So I wouldn't get too bogged down in it all, but it just helps kind of explain things a bit better, and I found that understood certain aspects of physiology better, actually having gone through that equation. Okay. It's Huffner, Huffner. Okay. Right, so moving on. Would a PE affect the dead space only because surely the lung would still be ventilated but not perfused in this space? Yes, exactly. A PE would increase the amount of dead space. Okay, so next question. So how is the majority of carbon dioxide carried in the blood? So is it A, as bicarbonate, B, bound to protein, C, bound to hemoglobin, D, dissolved, or E, bound to lipids? Okay. So as bicarbonate, fantastic. So that's 63% got as bicarbonate. And then we've got a few dissolved and a few bound to hemoglobin. Okay, lovely. So the correct answer is as bicarbonate. So here's our kind of table in terms of how carbon dioxide is mostly carried in the blood. So whereas we've already established by our equation that we've just gone through, the majority of oxygen carried in the blood is bound to hemoglobin. The majority of carbon dioxide is actually carried in the blood as bicarbonate. So we have a enzyme in red blood cells, among other places, called carbonic anhydrase. And this catalyzes the reaction of carbon dioxide plus water, which gives off carbonic acid, which then dissociates into hydrogen ions and bicarbonate. Okay. You'll notice that there's a difference between arterial and venous blood. So venous blood has a higher content of carbon dioxide, but it also carries the carbon dioxide in different proportions. We have about 60% of the carbon dioxide is bicarbonate in venous blood, whereas about 90% in arterial blood. We have more carbamino compounds in venous blood compared with arterial blood. A lot of this is due to the way in which hemoglobin carries carbon dioxide. So oxygenated hemoglobin doesn't buffer carbon dioxide very well, whereas deoxygenated hemoglobin has a much higher affinity for carbon dioxide. And this is where you get this drastic difference between the two, because your deoxygenated hemoglobin is a much better carrier of carbon dioxide. So we have a couple of eponymous names here. So that means someone has named a thing after them. So we've got the Haldane effect. So the Haldane effect is the increased affinity of deoxygenated hemoglobin for carbon dioxide. And then we have the Bohr effect as well. So the Bohr effect is the reduced affinity of hemoglobin for oxygen in high carbon dioxide environments. So that's what we were discussing before in the oxygen dissociation curve slides. So they're both fairly similar. One kind of says something which is almost the same as the other, and it's just kind of trying to remember the way around each of these are. So I like to remember that the Bohr effect has an O in it, and therefore it is bothered about the affinity of hemoglobin for oxygen, which also begins with O, whereas the Haldane effect is the carbon dioxide one. I don't have as good of a way of remembering them. Okay. So, carbonic anhydrase inhibitors were taught to us as a type of diuretic. Do you know how these drugs affect the carbonic anhydrase outside of the kidney? I don't know that, I'm afraid. Sorry, I think that has to be one for Dr. Google, I'm afraid. I'm not sure the answer to that one. What are carbamino compounds? So carbamino compounds are carbon dioxide is essentially bound to amino, basically means protein. So it's the binding of carbon dioxide to a protein. Often that would be hemoglobin, but it can be other proteins as well. Okay. Is everyone happy with that? Okay. Moving swiftly on. So, question 5. In the control of breathing, what senses low partial pressure of oxygen in the arterial blood? Is it A, the aortic and carotid bodies? Is it B, the central chemoreceptors? Is it C, the aortic and carotid sinuses? Is it D, the ventral respiratory group of neurons? Or is it E, the dorsal respiratory group of neurons? Okay. Okay, has everyone had a chance to answer that one? Fantastic, so the aortic and carotid bodies is 56%. And then we've got some for the aortic and carotid sinuses and some for the central chemoreceptors. Okay, so the correct answer was the aortic bodies and carotid bodies. Okay, so this is a bit of a busy slide, but it's just tried to include everything in terms of the control of breathing in, picture form. I'm quite a visual learner, so just having it all kind of with the arrows and things like that just kind of helps me to understand it a bit. So we have the peripheral chemoreceptors, so they are your carotid bodies and your aortic bodies. They predominantly sense the partial pressure of oxygen, but they also sense changes in pH and changes in carbon dioxide. We've got our central chemoreceptors, so they're found at the floor of the fourth ventricle, so and they respond to changes in carbon dioxide and pH within the CSF. So they both feed in their information to the respiratory center. So that's found in the medulla oblongata, and it's made up of the dorsal respiratory group, the ventral respiratory group, and the pneumataxic center. And then other inputs include higher senses, so things like fear, emotion, those kinds of things. We've also got the muscles of ventilation, so if things are getting too stretched, so we've got kind of baroreceptors which sense stretch, we will stop stretching any further and so kind of stop a breath from happening in that way. And then we've got other things, so things like if we're exercising, our brain tells us to start breathing fast far before our carbon dioxide levels start becoming too high and our oxygen levels start becoming too low. Okay, so going into the peripheral chemoreceptors a bit more, so we've got our aortic bodies which are found in the arch of the aorta, and our carotid bodies which are found at the bifurcation of the carotid artery. The carotid bodies have the highest blood flow in the body per 100 grams of tissue. So they have 1 to 2 litres of blood per 100 grams of tissue. And when we compare that with the heart, which is about 50 to 120 mils per 100 grams, or the kidney, which is 400 mils per 100 grams, that's really, really significant amount of blood flow. Because of this, the carotid bodies actually only need the small dissolved portion of oxygen, so that PaO2, the dissolved oxygen in the blood, in the arterial blood, in order to be able to respire, and so it only actually responds to that small partial pressure of oxygen, whereas the aortic bodies also respond to the oxygen saturations in the blood. The peripheral chemoreceptors only do a small amount of the control of breathing, and the vast majority of it is done by the central chemoreceptors. So what happens when the central chemoreceptors are working? So carbon dioxide dissolves across the dura and into the CSF. So carbon dioxide is a non-polar molecule, so it can cross the blood-brain barrier easily. However, once it's there, we again have carbonic anhydrase in the CSF, and so that catalyzes this reaction to make carbonic acid. And then the bicarbonate is actively transported out of the CSF. So with increasing levels of carbon dioxide, we get a higher pH of a lower pH of CSF, a higher acidity of CSF. The central chemoreceptors will sense this and respond to this and increase ventilation. Okay, now, as you can imagine, the peripheral chemoreceptors can respond to changes much quicker than the central chemoreceptors. So the peripheral chemoreceptors, they will use that oxygen and then send off their signals based on the amount of oxygen that they're able to use. So that's a really quick process in terms of being able to give feedback. Whereas the central chemoreceptors, that takes a bit longer. So that takes kind of, rather than your seconds for the peripheral chemoreceptors, it can take 1 to 2 minutes before the carbon dioxide is diffused across, and then this reaction happens, and then the bicarbonate is actively transported out. So for very fast response in respiratory depression, it would be your peripheral chemoreceptors that initially would respond to this, and then it would be your central chemoreceptors. The other important thing to do with the central chemoreceptors is, because of buffering in the CSF, for chronically high carbon dioxide levels, so if that carbon dioxide is high for a really long time, the CSF will buffer itself because it can't stay at a really low pH for a really long time, and therefore your body ceases to be able to respond to your high carbon dioxide levels. And in this is why we talk about in disease states such as COPD, that oxygen content of the blood becomes really important, because we can't respond to high levels of carbon dioxide anymore. Okay. So, does that all make sense? What would cause a change in pH of CSF? So, the change in pH is due to the carbon dioxide in water is catalyzed by carbonic anhydrase to form carbonic acid, and then we get that dissociates to form hydrogen ions and bicarbonate, and then the bicarbonate leaves the CSF by active transport, and we're left only with the hydrogen ions, and therefore that reduces the pH. So it's not the blood pH that's important, it's the pH of the CSF. Okay. Please, can you explain the buffering, CO2 and COPD again? Okay, so essentially in some patients with COPD, because they have really high levels of carbon dioxide normally in their blood, what's happened is over time, this reaction where you're getting the increased hydrogen ions and the bicarbonates leaving, this gets buffered by other molecules. So you've got things like phosphate and other things that can buffer the CSF. Because of this buffering, your central chemoreceptors can't respond to a low pH because the CSF is being buffered, and so the pH becomes normal. So despite high concentrations of carbon dioxide, you have a normal CSF pH, and therefore it does not tell your respiratory center to breathe more, and therefore your CO2 doesn't reduce because of that. So that's important for, like I say, for long-term states where you've got a high CO2 for a long time because of CSF buffering and the pH being normalized. You don't have that low acidity of your CSF, and therefore you don't have your central chemoreceptors firing and saying, breathe more. Okay. Does buffering normally occur in the blood? Yes, so we've got quite a few different buffers. So the bicarbonate buffer system, so we've just said how much bicarbonate we have in our blood is one of our really important buffer systems. We've also got proteins and other molecules which can help with buffering. Essentially all of our bodily processes happen best at a certain pH, because if you think about it, most of our things that we do to live require enzymes in order to function. A lot of the reactions that happen would not happen fast enough if we didn't have enzymes. And as we know from our biology in chemistry, A-levels and GCSEs, enzymes work best within a certain range, and they can become denatured if the range of pH becomes too far towards one side. Why does aortic body only respond to oxygen saturation? So the aortic body can respond to oxygen saturations and partial pressure of oxygen. The carotid bodies doesn't because of the blood flow to the carotid bodies. So we have so much blood flow to the carotid bodies that they don't need the oxygen which is bound to hemoglobin, whereas the aortic bodies, they get a much less blood flow. Is there any drugs that affect this? And if so, how? I'm not quite sure of the question. So we have drugs that affect the control of respiration. So drugs such as opioids, so morphine, things like that, can reduce respiratory drive, and therefore that can increase your carbon dioxide levels and reduce your oxygenation. So opioids work on various different areas. Other ones, so drugs such as those which we use to send people to sleep, so our anaesthetic drugs, and any drugs which can probably affect the muscles, so preventing people from being able to ventilate. So there'll be loads of different drugs which can affect the control of breathing, which is kind of goes beyond the scope of this lecture, which we're just kind of focusing on the core physiology. Do carotid bodies both respond to pH? Yes, so the carotid and aortic bodies respond to pH, oxygen, and carbon dioxide, but they predominantly respond to changes in partial pressure of oxygen, whereas the central chemoreceptors predominantly respond to changes in carbon dioxide. So because you've got your central chemoreceptors responding to the changes in carbon dioxide, and your peripheral chemoreceptors only do a very small part of the control of ventilation, they predominantly respond to changes in oxygen. Okay. Okie dokie. So moving on. Can you clarify the difference between aortic and carotid body response? Yeah, so the carotid bodies, they are found at the bifurcation of the carotid arteries. They have a really high blood flow going past them, and so they will they work by using that oxygen to as metabolism, or as respiration, creating energy. Small changes in the partial pressure of oxygen, so that small dissolved portion of oxygen, are really significant to them, and they respond purely to that partial pressure of oxygen, because that's the only part of the oxygen in the arterial blood that they use for respiration, cellular respiration. aortic bodies, they have a less of a blood flow, so they're not found at a junction between two major arteries, they're just found within the aortic arch, so it's just blood that touches them rather than at the bifurcation of the carotid arteries, a lot of blood is hitting them and a lot of blood is going past them. And therefore they respond to changes both in the saturations and the partial pressure of oxygen, because the partial pressure of oxygen isn't enough for them to purely do all of their respiration. Our carotid bodies and aortic bodies where baroreceptors are found as well. So it's the carotid and aortic sinuses where the baroreceptors are found. And so this is where things can become confusing, because we've got our aortic and carotid sinuses and our aortic and carotid bodies. So it's important to remember the bodies are to do with control of breathing, and our sinuses are to do with the blood pressure. Okay, so thanks for explaining the COPD buffering system. Can you quickly repeat how that then affects over-oxygenation in these patients? So in patients with COPD where they can no longer respond to carbon dioxide from the central chemoreceptors due to this buffering of CSF, it then becomes crucial to them that their peripheral chemoreceptors are working, because their central chemoreceptors aren't really working anymore. So if we're over-oxygenating these patients, so giving them way more oxygen than they need, then their partial pressure of oxygen, so their PaO2 in their blood, will increase. And therefore, you've got such a high concentration of oxygen in the arterial blood anyway, that your carotid bodies and aortic bodies are working fine because they've got enough oxygen going to them, despite the fact that the patient's not breathing very well. So you're getting your carbon dioxide starts to rise because the patient doesn't have anything telling them to breathe more, because their central chemoreceptors don't work and their peripheral chemoreceptors have enough oxygen. And therefore, the carbon dioxide will start to go up and up and up, because they're not able to blow it all away because there's nothing telling them to breathe. And that's why in certain patients with COPD, it becomes really important to make sure that we're not over-oxygenating them, because then they've got nothing that tells them that they need to breathe, and then they can go into respiratory depression. Okay, so moving on. So question 6, which of the following cannot be measured by spirometry? Is it inspiratory reserve volume, expiratory reserve volume, functional residual capacity, tidal volume, or vital capacity? Okay. So we've got 50% saying functional residual capacity, and then a few for inspiratory and expiratory reserve volume. Okay, so the correct answer is functional residual capacity. So spirometry, so you probably will have seen this graph before at some point during your study. So this is our spirometry graph. So essentially you've got a patient who's breathing through a pipe and they're breathing in and out. So you've got your tidal volume, so that's your quiet breathing where you're just gently breathing, not thinking about taking big breaths or anything like that. And that's usually somewhere around 500 mils for a 70 kilogram person. Next up, you've got your inspiratory reserve volume. So that's anything that a patient can inspire past tidal volume breathing, so past the inspiratory portion of tidal volume breathing. You've got your expiratory reserve volume, so that's anything that a patient can breathe out past the normal tidal volume breathing and past the expiration of normal tidal volume breathing. You've got your vital capacity, so that's if you ask the patient to take a deep breath in and then breathe all the way out, so that's as much as a patient can inspire and then expire. You've got your inspiratory reserve volume, which is around 1.5 litres, expiratory reserve volume is about 2.5 litres, vital capacity is around 4 litres or 4.5 litres. There's always a little bit of air left in the lungs, even after a patient is breathed out all the way that they can. That's called our residual volume. It's somewhere around 500 mils, and that just stops all of your alveoli from completely collapsing. You can't ever have a situation where there's no air in the lungs at all. And our functional residual capacity, that's the volume, or that's the volume of air which is left in the lungs during normal tidal volume breathing at the end of expiration for normal tidal volume breathing. So that's your expiratory reserve volume plus your residual volume. So that's somewhere around 3 litres. And you've got your total lung capacity. So that's the most air that can be stored in your lungs at any one point, and that's somewhere around 6 litres. Okay. So a few important definitions with spirometry. So it's important to know the difference between a volume and a capacity. So a volume is just that volume, so it's nothing added together. So for example, inspiratory reserve volume, tidal volume, expiratory reserve volume, residual volume. Whereas a capacity is the sum of 2 or more volumes. So we've got our vital capacity, which is inspiratory reserve volume plus tidal volume plus expiratory reserve volume, or our functional residual capacity, which is expiratory reserve volume plus residual volume. Okay, so that's the main difference between what's a volume, what's a capacity, is that the capacity is the sum of 2 or more volumes. So what can't be measured with spirometry? So anything that has residual volume in it, we can't measure with spirometry, because of spirometry, all we're doing is measuring what's being breathed out or what's being breathed in. So residual volume can't be measured because you can never breathe that volume out, and therefore anything that you need to add in with residual volume also can't be measured. So functional residual capacity, vital capacity, they can't be measured. There are ways of measuring residual volume. So we can use methods such as hydrogen dilution techniques or nitrogen washout techniques. We can also use a technique called full-body plethysmography, where you kind of have the patient in a box and are doing a similar kind of spirometry, but you're also measuring pressure within that box and pressure within the patient system. That kind of goes beyond the scope of this lecture, but just to let you know that there are a few ways of doing that, and letting you know a few of the names of what they are, just in case it happened to come up, but it kind of goes a bit further. Yes, vital capacity is inspiratory reserve volume, tidal volume, and expiratory reserve volume. Yes, that's correct. Why can't you measure vital capacity? Isn't this just, I mean total lung capacity. So it's total lung capacity, functional residual capacity, and residual volume. So it's just anything that has residual volume in there. Okay. So question number 7. Which of the following factors may cause a reduction in lung compliance? Is it increased surfactant, reduced alveolar radius, reduced alveolar wall thickness, increase in elastic fibers, or decreased surface tension? Okay. Yeah, so we're tied between reduced alveolar radius and decreased surface tension. Okay, so the correct answer is reduced alveolar radius. So the definition of a compliance is equal to a change in volume divided by a change in pressure. we often think about lung compliance when we think about blowing up a balloon. So if you think about how much effort, so how much pressure you're putting in at the start to get a very small change in volume of blowing up that balloon, the compliance is really low at that point because the change in volume is small for the amount of pressure that you're applying to that balloon. As you continue to blow that balloon up, the compliance gets, or the balloon becomes more compliant because you're having to put in very little effort to get large changes in volume. And then after a certain point, that balloon starts getting really full and about to pop. And then it becomes difficult again to get large changes in volume. Okay, so that's kind of how we think about the lungs. The area in which the lungs are most compliant is within that tidal volume breathing, which makes sense. That makes sense for the body to find it easier to breathe and to get those good changes in volume during tidal volume breathing. Okay, so we think about compliance, when we think about compliance and this change in pressure, we think about Laplace's law. So you may have seen this picture before where you've got this circle. The inward arrows are the surface tension, so that's the force which is pulling the alveoli closed and trying to get it to shut. And then we've also got the radius. So pressure within that alveolus is equal to 2 times the surface tension divided by the radius. So if you've got a higher force pulling that in, then that's a higher pressure. If you've got a smaller radius, then again, you've got a higher pressure to inflate that alveoli or alveolus. You may have seen this picture before as well. So without surfactant, can you please go over compliance balloon example, please? Yeah, so if we think about a balloon, when you first start off blowing a balloon, it's really small, but it takes a lot of effort to blow that balloon up or to increase the volume within that balloon to begin with, because it's really, the radius is really small and it can't stretch out for the amount of pressure that we're putting in. As we continue to blow that up, the balloon becomes more compliant. We get a bigger change in volume for the amount of pressure that we're putting in by blowing. And then eventually the balloon becomes really distended, about to pop, and it ends up being a lot of effort to then increase that balloon by further volume because of how the elasticity of the balloon is kind of at its limit, really. Okay, so without surfactant, the surface tension between alveoli remains the same. So in alveolus 1 here, we've got a radius of 1. So in this alveolus here, we've got a radius of 2. So in this alveolus with the radius of 2, I've called this one alveolus 1. Pressure is equal to 2 times 1, so 2 times surface tension. We've just said that the surface tension is 1. And then divided by 2, so that's the radius of the alveolus. So the pressure within that alveolus is 1. In alveolus 2, the radius is half, so we have 2 times surface tension, which is the same, which is 1, divided by 1, because that's the radius, and so the pressure within the alveolus is double, so that's 2. What that means is that the small alveolus, without any surfactant, has a tendency to collapse into the larger alveolus. It means that it's harder to expand those smaller alveoli. Okay. However, with surfactant, so surfactant is this kind of fluid which is secreted by a type of alveolar cell, which helps to reduce surface tension. We have more surfactant in smaller alveoli than we do in larger alveoli. So this alveolus, which is half the radius, has double the amount of surfactant, and so that reduces the surface tension by half. And so then we see that by adding surfactant into that lung, we are making the pressure within each alveolus the same. That stops that small alveolus from collapsing. Okay. Yeah, I can show the question again. Okay. So what we said by answering this question, we've said that a reduced alveolar radius, so it may cause a reduced alveolar compliance. However, we have the surfactant is in place to try and prevent any changes in compliance due to radius. However, if we didn't have that surfactant, we would have a reduction in compliance. Okay, does that make sense? Okay, dokie. Question 8. Okay, so surface tension. So I can explain surface tension. So surface tension is the inward pull. It's essentially the inward pull of between a fluid and gas or fluid and fluid interface. So that's the reason why bubbles are round, is because it essentially pulls that interface in to create the smallest surface area possible. And it creates this kind of inward pull. So we always draw these arrows if surface tension is pulling that alveolus or pulling that bubble in. So that's what would kind of antagonize the outward pull of breathing, essentially. Does that make sense? Okay, lovely. So next question. So a higher compliance will have a reduced radius. So no, so because compliance is proportional to 1 over change in pressure, and our equation is pressure, we're getting pressure here, you actually, the radius would be directly proportional to compliance. So an increased radius would cause an increased compliance of that alveolus, okay? So it would have been good if I had these two equations together actually in order to illustrate that point. So compliance is change in volume over change in pressure. And then pressure is directly proportional to 1 over the radius. Going back to the balloon example, and the compliance equation is the change in pressure in the alveoli. Going back to the balloon example, and the compliance equation is the change in pressure, the pressure in alveoli. So the lowest pressure is trying to inflate the balloon. So doesn't an increase in elastance also reduce compliance? So no, so when you've got an increase in elastance, your lung is more compliant because the lung is more elastic, so it can stretch more, which means that we can have a better change in pressure for a change in volume. If you've got a really fibrotic lung which doesn't stretch, you've got much more kind of restriction to changes in volume for a given pressure. Whereas if a lung is really elastic, as you change the pressure, the lung will expand much more easily. Okay. Lovely. So when flow is laminar, which single factor will cause the greatest increase in flow within the airways? So is it A, doubling the length of the airway, B, doubling the viscosity of the gas mixture, C, doubling the density of the gas mixture, D, doubling the changes in pressure across the airway, or E, doubling the radius of the airway? Fantastic. So we've got 62% are saying doubling the radius of the airway, and that is in fact the correct answer. So flow can be either laminar or turbulent flow. So laminar flow is where you've got everything flowing in parallel lines, the fluid flowing within the centre of that lumen is flowing at double the speed of that at the edges, or that in the mainstream, and the fluid flowing at the edges is almost stationary. So you've kind of got this parabola of flow where you've got your fastest in the middle and it slowly slows down due to friction of the walls of the lumen. And that's in comparison to turbulent flow, where you've got all of these whirls and eddies and disorganized flow. You might have some things flowing back on itself. Laminar flow is much more efficient. It means that flow can happen much more quickly, and we can get a much greater volume into an area when flow is laminar compared to when flow is turbulent. And it also means that the energy used to get the volume of fluid in that area is much less. Okay. So when we're thinking about flow, so factors which increase the likelihood of turbulent flow, so increased velocity. So if you think about a river, like a roaring river with the rapids and everything's running really quickly, increased velocity increases the chance that these eddies and swirls and things are going to happen. Increased density of the fluid, increased diameter, but decreased viscosity. So viscosity is kind of how thick a fluid is. So if you think about golden syrup flowing as opposed to water, the golden syrup would be much more likely to be flowing in parallel lines because it's really thick and viscous and kind of sticks together, as opposed to the water, which is far less viscous. Okay. We can use the idea of increased density or decreased density, increasing the chances of decreased density, increasing the chances of laminar flow, where if someone's got upper airway obstruction, we can use air mixtures which are less dense, such as heliox, which is oxygen mixed with helium. So it's a far less dense gas mixture, and that increases the amount of flow that can, or gas that can go into the airways and take part in gas exchange. Okay. For laminar flow, we've got the Hagen-Poiseuille equation. So this is one of anaesthetists' favourite equations. I must have been asked this so many times since starting my training. So flow is equal to pi times the radius to the power 4 divided by 8 times viscosity divided by length. So the biggest change that we can do in terms of increasing flow is to increase the radius of the airways. So in things like if someone's got asthma or secretions or something like that, blocking their airway, just opening that up a bit more increases the amount of air that can flow into the lungs and then take part in gas exchange. Here we go. Why does increased diameter increase the likelihood of turbulent flow? So when you've got an increased diameter, you've got far more space, if you think about it, for things to start veering off and going in their own direction. So increasing the diameter, increasing the number of bends, all of those kinds of things, anything that you can kind of think logically when you're thinking of that river analogy, when you've got kind of a narrow, slow meandering river compared with, your big, wide river with all the rapids in. So it's essentially just there's more of an area where that turbulent flow can take place. Can you explain that about density again? Okay, so in terms of density, so a reduced density will increase the chances of laminar flow, and laminar flow is better for getting air through the airways and being able to take part in gas exchange at the end of the airways and the alveoli. If someone has an acute upper airway obstruction and comes to A&E with it, we can use gas mixtures such as heliox. So if we think about normal air, which is in the atmosphere, it's predominantly nitrogen. So that's 2 nitrogen molecules together. That's got a much higher molecular weight than helium. So it's much more dense because of that, because the molecules are much bigger, and also much more much closer together. So in terms of trying to reduce that turbulent flow and trying to get air down into the airways, we can give a much less dense gas mixture to increase the chances of laminar flow and increase the flow within the airways. Is increasing the radius and diameter not the same? Yes, it is. Yeah, that is the same. So sometimes they talk about radius and sometimes they talk about diameter. I think we talk about diameter when we're talking about turbulent flow, because you can remember it as DVD, so it's diameter, velocity, density. So it's DVD. That's how I remembered it for my exams anyway. Whereas when we're talking about the Haldane-Poussey equation, we're talking about the radius, because you could do diameter, but you just have to half it first. Okay, which cells in the respiratory tract are responsible for gas exchange in the alveolus? Is it A, ciliated cells, B, type 1 pneumocytes, C, type 2 pneumocytes, D, goblet cells, or E, alveolar macrophages? Okay. Fantastic. So type 1 pneumocytes. So that's the correct answer. So we've got a few different types of cells in the respiratory tract. So when we're thinking about histology, we have these names. So the upper airway histology is classically defined as pseudo-stratified columnar epithelium. So if you see that in an exam, that's generally what it's referring to. So that consists of ciliated cells. So these are your cells which have the little hairs on the top, and they help waft any kind of badness up the airway, away from the alveoli, into the back of the throat, so that we can swallow those secretions. We've got our goblet cells, and they're the mucus producing cells, so they help to kind of stick the nasty stuff together so that it can get wafted up. And then we've got our basal cells, which are found towards the basement membrane. In the bronchioles, which are kind of the smaller airways, we've got our simple ciliated columnar epithelium. And instead of our goblet cells here, we've got our Clara cells. As we move down into the respiratory bronchioles, so these are kind of the first generations that are starting to take part in gas exchange. They may have a few alveoli attached to them. They are simple cuboidal epithelium, so they are small, the epithelial cells are starting to get smaller. And then our alveoli, they consist of our type 1 and type 2 pneumocytes. And then we have our various different cells, kind of immune cells like macrophages and things like that within each of these areas as well. Our type 1 pneumocytes are the ones that are responsible for gas exchange, and our type 2 pneumocytes are the ones that are responsible for producing surfactant. So they help with lung compliance. Okay. Do the bronchi have pseudo-stratified columnar? Yes, they do. So that's the trachea and the bronchi have pseudo-stratified columnar. And then once we move down to the bronchioles, then that starts to change. So as the airways get smaller, it keeps changing. Okay, and our last question. So in a healthy individual at rest, what is responsible for exhalation or expiration? Is it A, the diaphragm, B, the external intercostal muscles, C, the internal intercostal muscles, D, the elastic recoil of the lungs, or E, the accessory muscles? Okay. Lovely. So the elastic recoil of the lungs. Fantastic. So we've got our muscles of respiration. So we've got different groups. So we've got the diaphragm. So that's kind of the main muscle that involved in respiration. So that's our big kind of dome-shaped muscle at the bottom of the lungs, and that helps pull the lungs down and reduce the intrathoracic pressure and draw air into the lungs. We've got our intercostal muscles, so they're found between the ribs. And then we've got our accessory muscles. So these are muscles that aren't their primary feature, or the primary reason for these muscles isn't respiration, but they can help when we're needing to shift more air, for example, during exercise or when we're unwell. So during inspiration, we get a flattening of the diaphragm, as I was saying, you get a reduced intrathoracic pressure. And we also get contraction of the external intercostal muscles. So our external intercostal muscles, I've tried to illustrate in this slide here. So we've got that kind of cross-hatching going this way. What was the answer? So the answer was the elastic recoil of the lungs. So that we think about the ribs in having this bucket handle kind of motion in adults. So in children, they're very kind of straight and they don't really move very much. But in adults, they've got this bucket handle thing where they can kind of go up and down like this. The external intercostal muscles help to pull the ribs upwards and outwards, allowing that bucket handle to kind of flatten. And that again increases the volume of the thorax and reduces the pressure within the thorax, so drawing air in. What is used in forced inspiration and forced expiration? So we'll get to that point. Okay. So moving on, so expiration, so passive expiration involves relaxation of the diaphragm and external intercostal muscles and elastic recoil of the lungs, so that kind of pulls everything back. It increases the pressure and it forces air outwards, but it's generally a passive process. When we're kind of needing to breathe a bit faster, so if we were exercising, for example, we may need some additional oomph to help force that air out more quickly so that we can take our next deep breath in. And that's when we start having contraction of the internal intercostal muscles and the innermost intercostal muscles. So our internal intercostal muscles are crosshatched, but kind of in the opposite direction. And they pull the ribs, which are in that bucket handle, kind of that horizontal, and it pulls them back down and across. And then we've got our innermost intercostal muscles, so they're just going straight down, and again, they're pulling the ribs down. When we're breathing really hard, we also may need our accessory muscles to help with our breathing. So these are the muscles in the neck. So you've got our sternocleidomastoid muscle, which is this one here, your pec major and minor muscles, some of the muscles of the back, so the serratus anterior and latissimus dorsi muscles, and also your anterolateral abdominal wall. So that kind of helps with expiration. So when we contract our abdominal muscles, that increases our intra-abdominal pressure. That will help push the diaphragm up faster and help breathe out a bit quicker. So especially as you start moving along in your medical training and start seeing patients on the wards and stuff like that, one of the things in our respiratory examination is looking for any use of the accessory muscles. So if someone's kind of, you can kind of see these muscles going, or see them in kind of this tripod position, really, really working hard to breathe. That's when we kind of take those into account and start thinking about the use of those muscles. Okay. So when you inspire, you create a negative pressure. Is that the same as reduced pressure, which enables air to enter? Exactly. So a negative pressure means that you're reducing the pressure within the chest, and that draws air from the atmosphere and into the thorax. So more negative or reduced, essentially. And then when we're breathing out, we're increasing the pressure, or we're making the pressure in the chest less negative, and then that's allowing us to breathe out Okay. Is everyone happy with that? So it was quite long-winded. Well done to those of you that have stuck with it. I hope that you've learned something from it, and I hope that you found it useful. Like I say, I tried to stick to the core topics in respiratory physiology, so I hope that, you know, that helps explain a bit more. There's obviously so much to cover, and we were never going to be able to fit it into just 10 questions, but at least it gives kind of some starting point for you to kind of read a bit further. Does anyone have any last burning questions? I didn't manage to get down question 5. Would it possible to go back to that slide? Certainly. So probably a faster way of doing this, but what have I done?